Dan Roden is our speaker today. First, just want to thank Dr. Scheiman's help with coordinating today's talk as well. So, a little bit about Dr. Roden. He was born and raised in Montreal, Canada, where he received his medical degree from McGill University. After that, he went to Vanderbilt University, where he received his training in cardiology and pharmacology and has been there as faculty since. He's currently the professor of medicine, pharmacology, and biomedical informatics at Vanderbilt, where he also holds the Sam L. Clark Endowed Chair and serves as the senior vice president for personalized medicine. Under his leadership, Vanderbilt has become internationally recognized for cutting edge programs in this area of personalized medicine, including the large biobank of more than 350,000 samples and the EHR-based preemptive pharmacogenetic program, PREDICT. So I'm very excited today to have Dr. Roden join us and share with us his expertise in precision medicine. So I'll hand over the mic to Dr. Roden.
Well, thank you very much. I'm sorry I'm not there in person. It's just it's a long way to go, and I appreciate your indulgence in allowing me to do it this way. Someday we'll be back to in person everything, but uh, not soon. This is the title that I gave myself. Basically it's a story of it's an hour of or a little less than an hour of anecdotes, and I can pick lots and lots of anecdotes, but we'll start with a little bit of philosophy. So I get asked a lot about, personalized medicine and how can you do personalized medicine in an era where, the randomized clinical trial is king and everything is evidence-based as opposed to personalized medicine. And I think that those are not irreconcilable. I, I think it is important for us to recognize that most people are average for most traits. So, the idea of making sure that we deploy guideline-directed medical therapy for heart failure is really, really important, and that's evidence-based. What I can tell you, having sort of excavated in this field for a decade or two, more than a decade, is that everybody is far, far from average for some traits. You just don't know which traits, and we'll come back to that a little bit. So the trick is to find people who are real outliers and treat them different. Hmm, wonder what that was. So that leads me to this, what I call the fundamental paradox of personalized medicine, and that is in order to treat a subset of people differently from average, you have to have evidence for that. And the evidence comes from being able to create those subsets. And in order to create those subsets, you have to start with a very, very large denominator. So this is my idea that there's a large group population of patients, and somewhere in there are outliers for whatever trait you happen to be studying. So the opportunities are to find people who are going to be pharmacogenetic outliers. I'll talk about our pharmacogenetic program a little bit. Finding patients with unrecognized Mendelian disease and in an era of genome editing and new small molecules, developing and deploying new treatments for those people. Shortening therapeutic odysseys is something that we're all very, very interested in the neonatal intensive care unit and beyond. And then once you have a very, very large cohort of patients with common diseases like the ones listed here, you can start to develop subsets, a sense of what it is about the universe of patients with atrial fibrillation that makes some of them different from average and treated differently from average. And I will end on that anecdote in 45 minutes. So I came to Vanderbilt to study clinical pharmacology, the science of trying to understand why there is variability in response to commonly used drugs across patients. And I was very fortunate that at the very beginning of my career, I studied a drug that had a big, big pharmacogenetic story. So there's a big genetic story around variability in drug response. This is my version of a DNA molecule in Vanderbilt colors. The other thing that distinguished Vanderbilt at the time I came, well, not so much at the time I came, but shortly after I arrived, was an institutional investment in biomedical informatics. We had leadership that recognized very, very early that that was going to be important. So very few people on this call, some I suspect, but very few will know what this is. This is a medical record room prior to the advent of electronic medical records. So you would, at 3 o'clock in the morning, go to the medical record room with a patient that was in the emergency room and hope that you found the record and hope that the record was up to date. Usually it wasn't, and usually you couldn't find it. So those people who complain a lot about the electronic record need to remember that it was even worse before the electronic record. And we invested early, and biomedical informatics as an entity is now a department, fourth largest department on campus after medicine, surgery, and pediatrics, with over 150 faculty members now. So we had a retreat 20 years ago now, where we try to decide what to do with ourselves and where we should put our resources. And one of the commitments was to personalized medicine. So if you do a PubMed search on Vanderbilt and personalized medicine, this is what you get. And I'm particularly happy with the very first publication. The very first publication described the design of our biobank. Now, our biobank, if I had to do it again today, I would design it a little bit differently, but it was one of the first efforts to marry electronic records to DNA to understand that. So this is the sea of samples that we accrued on the very first day we started collecting samples in 2007. So the idea is that the phenotype is this, what we call the synthetic derivative. And that is a de-identified image of the electronic health record, almost 4 million records going back decades in some cases. BioView is a subset of that. The current number is 350,000. Hasn't changed much since Evelyn got the script to read, but it grows obviously at some finite rate. And the consequences of creating the biobank for Vanderbilt, I think, have been pretty far-reaching. It's not a toy that 3 people use or 10 people use. It's a toy that many, many people use, and many, many, many fellows, residents, students use it as part of projects. Lots and lots of publications, lots of projects, and lots of NIH grants, the largest of which supports the Data and Research Center for the All of Us initiative, which I'll talk about in a little bit. When people ask me what's the most important part of the biobank, I think the most important thing is that we have created new science, which I'll describe a little bit. We have new faculty who are expert in that science, either because they are trained here or because they come here because they want to play in the biobank. We have great examples of that, and trainees who want to come because of the biobank or end up working in the biobank. So the original idea was pick a human trait, name a trait, disease, drug, complication of a disease, use dense genomic information to find, where in the genome is there an association to the trait, which genes and which specific variants modulate that. So the idea was to do discovery and then figure out how to implement that discovery. So we have an interface, which we call the record counter, available to anybody with a Vanderbilt ID password. This is not an IRB thing. The question that you ask when you interrogate the record counter is, how many patients do we have with disease X, or disease X and drug exposure Y and genome Z? And this tool allows people to just see if there's feasibility to a question they might have. So I sometimes do this in real time. I never, the site is not always up, so I'm going to show slides. This is what happens when you interrogate and ask how many patients we have with atrial fibrillation. Interestingly, this number and this number are a little bit different. There's a reason for that. And if somebody wants to ask me, I can tell you why that is. And this is interrogating the electronic record. And then if you want to interrogate BioView, you have to tick on here. And then the number goes down, obviously, because it's a subset. And so we have around 17,000 patients with atrial fibrillation and a DNA sample. And we've done a fair amount of genotyping. This is one of the popular platforms that we use is the Illumina Mega Array, interrogates about 1.7 million SNPs. And there are 100,000 patients who have that data in their BioView record. And the intersection between these two sets is 10,000 patients. So we have 10,000 patients with dense genotypic data And we've contributed those to all the GWASs for atrial fibrillation that Patrick Eleanor and his group have published. About 3 years ago, 2.5 years ago, we announced a deal where we would uh, partner with Illumina and with nine pharma companies. This is five, but there are actually nine in the Alliance for Genomic Discovery (AGD) to sequence 250,000 samples from the biobank. So that's whole genome sequence. That project went ahead. And actually, last week I should have put a slide in here. Last week it was announced that the last sample was sequenced. They're not all available to us yet because they have to go through a QC process, and I'll show you how many are available. But as soon as they're through the QC process, they're available to Vanderbilt faculty along with the AGD partners. So the size of the data set before we did sequencing was small. I mean, 80 gigabytes, fits on many personal computers, could even fit on your phone. Um, and that includes the electronic record and all the array data. Now, once we go to sequence data, we skip terabytes and we're into petabyte territory. So you can't do that on your phone or on your laptop, and it's all in the cloud now. And moving to the cloud was a production, but that's what we had to do. So now, if you interrogate and ask for how many people have AGD data, this is hot off the presses of yesterday. 222,000 have whole genome sequence. And as of now, and the number will be bigger once the data set is finalized, there are almost 12,000 people with whole genome sequence data and atrial fibrillation. So you want to study atrial fibrillation, that's a good place to do it. And we can click there and get a breakdown of ancestry, age, and gender. So resources like that have allowed people to find cases and controls, and I have 8 million examples of that. And I'm going to show one, which is actually old now, but I really like it. It's a relatively small study that looked at people. Everybody in this study was on a statin, looked at people who had an ACS event on statin and people who did not have an ACS event on statin. Did a genome-wide association study and found a locus that associated right here at statistical significance. And that locus is smack in the middle of LP little a, which of course is everybody's favorite drug target these days for residual risk after statins. So I'm not going to give you any more examples, simple examples like that. So I was sitting in a conference room in 2009 or so, and we were talking about this idea. We were just starting to get genotype data. Our first genotyping exercise was 50 common SNPs in 15,000 patients. So we've come a long way since then. And somebody said, well, we could turn this experiment on its head. We could say, here's a particular variant. With what human phenotype is that variant associated? And I was in the room when the term PheWAS was invented, Phenome-Wide Association Study, to describe this. So this is from a paper that validated the PheWAS methodology. I'll tell you about that in a second. And I'm fond of saying this is a typical example. This is, of course, the best example I've ever seen. There's a SNP in IRF4 that associates with red hair and blue eyes. And if you do a PheWAS, you get a very, very strong association with skin diseases, actinic keratosis with a p-value of 10 to the minus 26th or so, and then a series of non-melanoma skin cancers here. And the diagnosis that I particularly like is solar dermatitis. Solar dermatitis is the electronic medical records version of sunburn. So I like to refer to this picture as the fanciest way of showing that people with red hair get sunburns more easily than other people. We validated that in a large resource called the Electronic Medical Records and Genomics Network, which we became part of in 2007 and we're still part of. And so this was a high-profile article in Nature Biotechnology that really showed that the methodology works to replicate many genome-wide association study results and can do new discovery. we thought Nature Biotechnology was a pretty high impact journal, but Josh Denny, the first author of the paper, was also featured in an even higher impact medical journal, the New York Times. And it was a really very clever article because it's a complicated concept to transmit to lay people, and Carl Zimmer did a really wonderful job of doing that. And FIWAS is part of the genome science lexicon now. There are hundreds of papers that use that, and every RFA that comes out of the Genome Institute talks about FIWAS. So we've used FIWAS over and over and over again in many, many, many different concepts. I'll just give you two quick examples. One of them is one of our earliest examples. This is we did a genome-wide association study as part of eMERGE to look at markers of QRS and PR variability. And one of the SNPs that we landed on was actually near the cardiac sodium channel. And then Josh Denny went back and said, I wonder with what other phenotypes that might associate in the electronic record. And this, it turns out that your genotype at that particular SNP associates with atrial fibrillation risk. And the reason I like this slide is that it illustrates this idea of using the electronic record. There are 20 years of follow-up here. And I don't think, a clinical trial has real trouble doing that. The electronic record does that. The electronic record has warts. There's no question about it. But this is one of the advantages. And then the other highlight that I thought I should show is this one. We every non-African ancestry person has admixture in their genome with Neanderthal genomes. Around 1 to 3% of your SNPs come from that admixture event. And the question that Tony Capra, who's actually at UCSF now, tried to address in this study was with what human phenotypes do the residual Neanderthal SNPs associate? The answers were, sort of a blood coagulation phenotypes and smoking phenotypes. I have no idea what that has to do with Neanderthals. But I think the reason it was in science was it's just such a cool idea. So that's what happened with that story. So this was a picture from the NHGRI strategic plan published 5 years ago, and it illustrates this idea that there is a constant interchange between basic research and clinical implementation. So I have lots of anecdotes, which I'm going to tell you about now, little stories around this. Some of them more in the basic science space, some of them in the implementation space, but all of them are this interface between the two. So the first story is Lisa Bastarash's idea. So Lisa is a biomedical informatics data scientist, a brilliant data scientist. And she set out to ask the question, can I find people in the electronic record who have cystic fibrosis? Now, the easy way to do that is to search for the codes or search for the word cystic fibrosis. But she said, no, I'm not going to do it that way. What I want to do is search for people who have combinations of phenotypes that look like cystic fibrosis. So here are 3 patients who have phenotypes. This one has a lot of phenotypes that look cystic fibrosis like bronchiectasis, failure to thrive. This one has pancreatitis and bronchitis, sort of could be cystic fibrosis, could be lots of other things. This one has nothing. So there's a way to give a weight to each of these. And these are the weights that she derived from the electronic medical record itself. And then you add up the weights and you get a score. And the question is, does the score identify people with cystic fibrosis compared to people who don't have cystic fibrosis? And in this particular example, it does. They normalize the scores to z-scores. And there's a big difference between diagnosed cases, which we have some of at Vanderbilt, and controls who we assume have almost none. And in that paper, we described 6 diseases, 6 common diseases, and the p-values are pretty respectable. 5 times 10 to the minus 220 is a pretty, that says the score works pretty well. It turns out we don't have very many undiagnosed cystic fibrosis people. So the idea was to use this to find people with undiagnosed disease, but we actually think we capture most of those. And you can see that there's a pretty respectable p-value for all of these diseases when you do a phenotype risk score, except for phenylketonuria. That was a surprise and a disappointment until we realized that people with phenylketonuria are diagnosed at birth and put on a diet. So they have no symptoms. So their electronic medical record doesn't have anything in it. And so the p-value is 0.28. So it's a great control, actually. And this is a case that Lisa published actually a couple of years later in the informatics literature. A patient who's 59 gets pneumonia, then presents with pancreatitis, then gets a diagnosis of chronic airway obstruction, then gets a diagnosis of bronchiectasis. So around here, people should have started to get concerned. The phenotype risk score is going up over time, and the diagnosis is made over here. Of the adults we have with cystic fibrosis at Vanderbilt, the ones who get a diagnosis all have a phenotype risk score in the 95th percentile before they get a diagnosis. So we think that this is a way of tagging people, although it turns out to be low yield for this particular disease. But we're interested in doing it for other things, and we use the phenotype risk score in a variety of contexts, which I'm not going to talk about. I talked a little bit about this morning. I can't resist showing you a couple of slides of work that we're doing around the problem of variant of unknown significance. So this is an 11-year-old who had a witnessed cardiac arrest on his first day of school. He had VF and was resuscitated by an AED shock. And if anybody wants to think about advances in cardiovascular care, this is a huge one. I mean, the idea that I can actually present this case and know what the answer is remarkable because we have AED technologies deployed in the community. This is his cardiogram. He has a long QT interval. He also had exercise. During exercise, he had bigeminy at peak, which is an unusual response in long QT syndrome. And he has we do in-house genetic testing. He has two variants of uncertain significance in a gene called calmodulin 2, which is associated with long QT and with CPVT. So he has features of both. So this looks like it could be causative, but it's a variant of uncertain significance because it's never been seen before, this combination or these two variants. So the scope of the problem is this, that I'll take my favorite gene is SCN5A, so the cardiac sodium channel gene. Several years ago, we curated about 1,400 variants and asked the question, how many of them are pathogenic, how many of them are benign? And some of them are pathogenic or likely pathogenic according to widely used classification schemes, and some of them are benign or likely benign, again, according to widely used classification schemes. And most of the rest are variants of uncertain significance. The problem with variants of uncertain significance is that you can't act on them because you don't know whether they're pathogenic or not. My colleague, Fritz Roth, made what he calls a back of the envelope calculation a long time ago now, and said, basically, if you take the consideration of the size of the genome, the number of people on the face of the planet, and the de novo mutation rate from generation to generation, we each have about 30 to 50 changes in our nucleotide sequence from generation to generation. Every SNP that can possibly exist that doesn't kill the embryo is present on the face of the planet in dozens of people. And the reason we haven't seen them is because we haven't sequenced everybody in Somalia or Uruguay or in Fiji. So the variant of uncertain significance problem is not my 1,300 variants here. It's the 38,000 possible variants that it can exist in the cardiac sodium channel. So the genome community wants to solve that problem, and the way we're solving that problem is using something called multiplexed assays of variant effects, or MAVES. And this is the general scheme for MAVES. So we take a group of plasmids that include our gene of interest, and we make every single possible mutation in our genomic region of interest. We also insert a barcode. You can see they're color coded here. And the barcodes turn out to be important for the analysis later, but I'm not going to dwell on those. And then we transfect them into a pool of cells that have been engineered so each cell accommodates exactly one insert and no more than that. We can also do this. We're also starting to do this in iPS cells. The editing allows us to do that in situ, but it's hard to edit and get thousands and thousands of variants, but we're getting there. So you have a pool of cells, that millions of cells, that each one of it is expressing one variant in your genomic region of interest. You do something to the pool. you challenge it with a drug, you see how many channels are on the cell surface or not. There are a variety of assays that we use, and um, and then you sequence the pool before the challenge and after the challenge. And then we display the data as what we call a variant effect map. So the map is every amino acid position on the x-axis and every possible genetic variant on the y-axis. So there are going to be 21 rows, 20 amino acids, and one stop codon at every position. So this is what a variant effect map looks like. This is a variant effect map actually for calmodulin. There are three calmodulins, calmodulin 1, 2, and 3, separate genes encoding exactly the same protein. So this is a calmodulin variant effect map. A green cell is pathogenic. A blue cell is thought to be benign, a variant. So we did this in this patient that I presented to you and a couple of other patients that was reported a year and a half ago. And the two variants that we saw are both pathogenic. So they're in cysts, and there's reasons to think that that means that it's really pathogenic. And that means that this variant moves from variant of uncertain significance probably to likely pathogenic, not pathogenic. That's the way the classification schemes work. We have a very, and I was telling people earlier that I was at a conference over the weekend and somebody presented a VUS in calmodulin 1 that was D130N. So I could look on the map and I could say, well, look, that one's pathogenic. It's not a VUS. So we have a very large award from NIH to create these maps for many Mendelian uh, cardiovascular diseases, including arrhythmias, cardiomyopathies, and lipid disorders. These are the cast of characters at Vanderbilt. At Stanford, you may recognize you and Ashley and Vicky Parikh. Fritz Roth is the man whose work I quoted earlier. He was at Toronto. Now he's chairman of a department in Pittsburgh, and Callum McRae at the Brigham. And I shouldn't say our major accomplishment, one of our first accomplishments was to create a logo. So that was really important. Um, so this is one of the first maps that we actually generated under support of that award. We studied KCND1. Again, the x-axis is the position in this 129 amino acid sequence. The dots are the wild type residue, and these are the variants that are annotated in a database called ClinVar that's maintained by the NIH. And they annotate variants when people send them an annotation. So this is all the variants that are annotated in ClinVar. And this is what a variant effect map looks like when you've done all the variants. So our idea is to combine these kinds of data with structural data that is either real structural data or in silico calculated structural data using programs like AlphaFold and AlphaMissense, and data from very, very large repositories like BioView, like the UK Biobank, like all of us, to understand not only whether variants really are pathogenic, but what the penetrance of those pathogenic variants are. So that's a whole other story. I talked about it this morning, and that's all I'm going to say. These are maps of major cardiovascular disease genes that we've generated. This one's been published. This one is close to being published. This one is under review, and this one will be under review within the next 3 months. So big maps, lots and lots of variant data. And the idea is those will be publicly available. Those are publicly available. And when we get a VUS, we can look up what the score is. So I want to talk a little bit about pharmacogenomics, because that's how I sort of started my career. And this is what people think of when they think of implementing genome science. So I love this cartoon. I show it all the time. This is published in the New Yorker in the year 2000 when the first draft of the human genome was unveiled in the White House. This woman is handing her sequence on a piece of paper. And I'm pretty sure that that's not the way it's going to work. It'll be a QR code on your cell phone, I think. She's handing it not to a physician, but to a pharmacist. So this is team sport, and he has no idea what to do with it. And we're sort of in a similar position with a lot of genome variants right now. I think we're a little better than 25 years ago, but not completely there. So when people think about low-hanging fruit in terms of implementation, pharmacogenetics is always cited, and I'll tell you how we've done it and why it is not exactly low-hanging fruit, but it can be done. Um, my story starts when I was a very junior faculty member, and this is one of my mentors, Grant Wilkinson. Grant was studying a drug called mefenitoin, a drug that no one here has ever prescribed because I don't think it ever was on the market. And there was a story that he had heard that there was variability in metabolism. So he studied about 100 people and found three or four what he called poor metabolizers. They were unable to detect the major 4-hydroxy metabolite in the urine. So these people didn't make the metabolite. Most people did. And I remember giving Grant a hard time because I said, you're studying a drug that no one's ever going to use. What's the point of the exercise? So hold that thought. So 1998, clopidogrel was approved. It was known to be a prodrug, so it needs to be bioactivated. The bioactivation pathway was not known. And in 2006, the bioactivation pathway was described as CYP2C19 loss of function variant. So you lose function of this enzyme and you can't bioactivate the drug. And it turns out, of course, S-mefenitoin 4-hydroxylase is CYP2C19. So Grant was right and I was wrong, as usual. And these are the original data from Jean-Jacques Boulot. It studied a very small number of people who had either the wild type genotype or heterozygous for the major loss of functional allele in European ancestry individuals. So at baseline, the platelet aggregation is very similar. Day 7 after clopidogrel, 75 milligrams a day, there is a clear antiplatelet effect in the wild type people, and there is, on average, no change in the people who are heterozygous. And the problem, of course, is that there's tremendous variability. Some of these people don't have an antiplatelet effect. Some of these people do have an antiplatelet. So there is variability, but on average, you look in populations, that's the way it works. People have done genome-wide association studies looking at platelet aggregation. And what's interesting, and I won't dwell on this, is that it's a highly heritable trait, 73% heritable, but the heritability is attributed to we don't know what, but only a small portion of the heritability is attributed to CYP2C19 star 2, which is the major European ancestry variant. There are other variants in other ancestries, which I'll tell you about in a second. And there are clinical trials that if you're a carrier of one of these loss of function variants, your incidence of MACE events after stent placement is higher than if you're a non-carrier. These are old trials, but those are the data, and we replicated those data in BioView very, very easily. This is a clinical trial that took years to do. This is a biomedical informatics exercise that took a couple of weeks to do. So we're designing PREDICT, our pharmacogenetic preemptive program, and the FDA adds pharmacogenetic information to the clopidogrel label. And basically it said, consider alternative treatment in patients identified as CYP2C19 poor metabolizers. It didn't say go and genotype them. It just said, if you happen to know, do it. And so we started our PREDICT program with clopidogrel. And then we rapidly added other drugs that you see here. And after this set of drugs, we actually looked back at the first 10,000 people that we had typed, and almost everybody has a variant that would be interesting if you got one of these drugs. Trouble is, you don't know which variant, and the likelihood of you getting one of these drugs is not 100%. It's way less than 100%. The program has evolved since then. We now do about 25 or so drug gene pairs, and we're always looking for further opportunities. These are all focused on individual SNPs that have relatively high effect sizes in the presence of a drug. This is what the report looks like. This is sort of illegible gobbledygook, and this is actually my report, but it doesn't say that anywhere. If I were a poor metabolizer for CYP2C19, which I am not, you can see that I'm not one of those. Then as soon as my prescriber prescribed clopidogrel, this pop-up would appear and say, you're really sure you want to do this? Think about other drugs. Think about whether you really want to do this or not. It doesn't say you have to. It just says, here's the information. You do with it what you want. And we've looked at responses across many drugs, but this is a response looking at clopidogrel response. So the factors that affect whether people pay attention to this advice is how long does it take between the time we do the assay, the time the patient starts the drug and the assay result. If that's 2 months, then nobody cares because by then the period of major risk has come and gone. And so the predictors of change are whether you're a homozygote or a heterozygote, which is interesting because doctors pay attention to the fact that the effect in homozygotes is total loss of function. Heterozygotes, they still have some function, age and type of stent. And one of the other predictors is who you are. There are some cardiologists who like to do this and like to pay attention and will change often. There are other cardiologists who really don't pay attention at all. These are old data. We think they're changing, and the change is slow, and it depends on peer pressure, and it depends on institutional pressure and other factors. So when we were designing Predict, the FDA published this label, and there was an immediate vociferous pushback from the cardiology community. This editorial appeared in JAMA, Irrational Exuberance, and basically saying, there's no randomized trials. So how can you possibly get excited about this? Time has passed. There have been randomized trials of clopidogrel. There have been randomized trials of other pharmacogenetic results. I'm not going to show them, just to say that they all point to the idea that genetics really do improve outcomes measured in a variety of different ways. And then most recently, there was a big trial across Europe in 7 countries looking at 42 drugs using a 12-gene pharmacogenomic panel, not unlike ours at Vanderbilt, and looking specifically at adverse drug events. And the idea was to reduce adverse drug events, which they estimated would occur in 20% or so of patients, reduce them by 30%. So they had a large number of people randomized to usual therapy, large number of people randomized to pharmacogenetics. It's a complicated design, crossover design, multiple languages, multiple hospitals, some of them cancer hospitals, some of them psychiatry hospitals, all during the pandemic. So a messy, messy, messy trial. But when you looked at the final outcome, and there are many ways to look at it, there was a striking reduction in adverse drug events in people treated with, this is the reduction, so 40% reduction versus 10% reduction in adverse drug events when you used pharmacogenetic information. The American Heart Association has recently had a scientific statement that CYP2C19 genetic testing is reasonable for clopidogrel treatment. It doesn't say you have to do it, but and the question is how to do it, whether you do it at bedside or whether you do it as a preemptive panel. Those are open questions still. But this is the algorithm that is suggested. So if you have a variant, then use something else. If you don't have a variant, clopidogrel is as good as these other drugs and probably causes a little less bleeding. The other issue around CYP2C19, which is generic to all of personalized medicine, is the idea that allele frequencies vary by ancestry. So the European ancestry, 2%, this slice here is homozygote loss of function. And this 26% is heterozygous loss of function. So these are the people that we're interested in. And it's similar in sub-Saharan Africa and Afro-Caribbean populations. But look what happens when you get out to the Far East. In East Asia, much higher incidence of total loss of function and much higher incidence of partial loss of function. In fact, a majority of subjects are like that. And of course, if you're in Oceania, almost everybody is either complete or partial loss of function. So the state of Hawaii, where there are lots of Oceanians, sued Bristol Myers Squibb and came away with $1 billion. Whether they stood up at appeal, I don't know. But this is another way of making sure that pharmacogenetic testing gets implemented. Get the lawyers involved. I'm not sure that's a great idea, but there it is. And there's an undercurrent in the cancer therapy world right now. There are rare variants in a gene called DBYD, which predispose people to fatal toxicity with 5-FU. So that happens relatively rarely, but that's one of the reasons we've added DPYD to our panel. And this is, again, another story around a large settlement in an individual subject. And then I wanted to just present this case because I think it's cool. This case was presented by my primary care doctor when he did medicine grand rounds. He's interested in how to use the electronic medical record to interface with people. So this is not me. I'm not a sociology professor, but so this is a patient of his who's a 65-year-old sociology professor, past history of hypertension, COPD, and a PCI to the LAD. Probably had clopidogrel at the time. He wasn't sure. He was on vacation and he was admitted to an outside hospital for a PCI for an ACS event. Had another PCI, and clopidogrel was started or restarted. And it turns out that in his pharmacogenetic information, he's an intermediate metabolizer. He's a heterozygote for loss of function, and it's shared with the patient in our patient portal. This is what it looks like in the patient portal. Based on the results of your test, your genes may increase your risk, blah, 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 blah. And so when he sees his PCP, he says, I noticed on my health at Vanderbilt that I'm not supposed to be taking Plavix. And the PCP looks at that and says, oh, you're right. And the reason the advice didn't fire is because the prescription wasn't written at Vanderbilt. So, when he comes, it's an old prescription. We don't fire on old prescriptions because otherwise we drive everybody crazy. So the PCP communicates with the cardiologist, and like within minutes, the prescription is changed. But it illustrates the problem of who owns the data and who's responsible for making sure it happens. So there's this. So I'll just say, in summary, around the pharmacogenetic stories, it should be simple. The alleles are very common, so they're easy. They have big effect sizes if you happen to be taking the drug. There's not a lot of angst around revealing this to patients. When you talk about susceptibility to FH testing or BRCA1 testing, people get nervous. They're not sure they want to know. They're not sure the whole family wants to know. But for pharmacogenetic traits, there's really no angst around that. And electronic medical record systems can be engineered to do it. The problems are that the alleles are common, but the combination of an allele and a drug therapy is less common. The assays are actually pretty complicated. Some of the things are gene duplications in regions that have pseudogenes and regions that have lots and lots of extraneous SNPs that are hard to sort of sort through. There are thousands of variants of uncertain significance in pharmacogenes, and people are using variant effect maps, generating variant effect maps for those, so we can start to use those. And then this business of a time lag between genotyping and medication prescribing. So the 65-year-old sociology professor I just described, whose problem is that? And I think right now the patient needs to own those data, because if that professor moves to Seattle or San Francisco, the data have to go with them, and we have to figure out a way of making sure it's portable and making sure it's still useful. Rare adverse drug effects are rare and hard to study in randomized clinical trials. And the question is, do you do a randomized clinical trial for every single drug gene pair? You can't do that. And there's just general discomfort, and reimbursement is a mess. So one way to solve problems is to write them down. So I've written them down, and we're working on solving some of those. Some of those are beyond the academic medical community's problem, like the reimbursement issue, but we'll get there, I think. So I've talked a little bit about health records and genomics, but personalized medicine or individualized health, or whatever you want to call it, involves a lot more than that. It involves other omics. It can involve images. It can involve data streams from devices like cell phones or smartwatches. A lot of variability in individualized health has to do with socioeconomic circumstances, like how close you are to a grocery store or your education or income level. I take medicines once a day, and at least once a month I forget. And I'm about as obsessive a patient as you'll ever have. The idea that we have very complicated medical regimens, 3 times a day for this one, twice a day for that one, alternate Thursdays for the other one, and people can be adherent to that, is far-fetched. So I think that's another problem in therapeutics. And then I couldn't resist sticking a picture of iPS cells in here because we're doing a lot of work in that. I haven't shown any of it. It probably won't show any of it. But that's an aggregation of cardiomyocytes that are beating, so we think they're heart cells. So the challenge is to figure out how to integrate all those forms of information. And that's one of the things that the All of Us initiative is doing, and hopefully will continue to do. But who knows what goes on in Washington D.C. Uh, today, this hour, could change next hour. So we are the data and research center for the All of Us initiative. Our mission is to find the data, clean the data, curate the data, and share it in a secure environment. I'm fond of saying Vanderbilt is the data and research center with junior partners of Verily, Google, and the Broad Institute. So this is what the data repository looks like right now. Over 500,000, actually over around 800,000 people have signed consent forms. There are electronic records in many, survey responses in many, physical measurements in many, 400,000 whole genome sequences, 100,000 structural variants, 30,000 long read whole genomes, a total of 1.3 billion SNPs. The number that the limiting number is going to be 9 billion. There are 3 billion SNPs. There are 3 billion nucleotides in the genome, so 9 billion SNPs is the number we're aiming for. Arrays, Fitbit records. That's the data set. And one of the things that is really interesting and really near unique about the All of Us initiative is that there's a deliberate attempt to return genomic information to participants. These are not patients, these are not subjects. They're participants in a research study. So we've returned genetic ancestry, we've returned some pharmacogenomic data sets, and the number here is 89% had at least one clinical actionable pharmacogene variant. And we're returning hereditary disease risk. In the ACMG 59, people will say, well, the ACMG is up to 82 or whatever the number is now. There's a complicated reason why we're limited to 59. And so far, out of these group, there are around 3,000 who have a pathogenic variant. So that's an interesting number. And what happens to those people is something that's going to be followed. And I want to close by telling you this story, sort of an implementation story. So this is a 29-year-old man I saw in clinic. He's asymptomatic. He has a very strong family history of hypertrophic cardiomyopathy. His mutation in his family is known, and the proband in his family is his first cousin who has exuberant HOCM. There are other people who have HOCM in the family, and he comes because he wants genetic testing. And he comes with an echo that is completely normal and an electrocardiogram that's completely normal. So I said, look, it's the year 2020 or 2021 or whenever it is I saw him, and we can do this genetic test, but it's going to be negative. We charge $49 for this test, so it's a pretty simple test to do. And he agreed to do it, and so that was the end of that. And then 4 weeks later, he's on my clinic list again, and I told my clinic nurse that's a Vanderbilt scheduling error because nobody comes 4 weeks after their test. And she said no. He called. He needs to see you again. And so I said fine. And so he was mutation positive, and he had been seen twice in the intervening 4 weeks for atrial fibrillation. His MRI is normal. He's been followed, and he's on propafenone and a beta blocker and an anticoagulant, and he's fine. And doesn't have any evidence of ventricular involvement. My colleague Ben Shoemaker has been accumulating cases of early onset atrial fibrillation from our clinics for years and years. Actually, the accumulation started long before he joined our program. And so we had almost 1,300 people with atrial fibrillation onset before age 60. As part of the TopMed program, we got whole genome sequence in them. We were able to look at 175 candidate genes. I thought the candidate genes we should be looking at were channelopathy genes, and it turns out that we should have been looking at cardiomyopathy genes. So about 10% of people are positive when we do it this way. The younger you are, the higher the positive rate. And the commonest disease gene we find is Titin. And after that, MYH7 is the second most common. And then MYH6 was an atrial specific, supposedly atrial specific myosin heavy chain, and then others asthmatogalactose, including a channelopathy gene. So we now have a best practice alert in Epic that says this patient has atrial fibrillation and is young. And people who are young with minimal risk factors may have a genetic contribution. Consider referring to the Atrial Fibrillation Precision Medicine Clinic, which is how Ben Shoemaker spends all day Thursday every week seeing patients who are referred to this clinic. The first slice of results was presented at HRS last year, and there were 250 people who were sent to the clinic, and 20% had genetic testing that was positive. That's different from the 10% in the original paper, and we think that's because the people who refer have a sense of who might be genetic and who might not be. We think that's what it is. The negative people, some of them have a VUS that might turn out to be real, and some of them are heterozygous carriers for something that is recessive, and some of them have nothing. So the goal of the clinic is to figure out whether we change therapies because of these results. Do we institute anticoagulation earlier? Do we look much harder at the ventricle? Do we do guideline-directed medical therapy much earlier? Do we implant defibrillators in people with an ejection fraction of 47%, but with a bad Titin mutation? Those are the kinds of things that we're trying to figure out. So what is the utility of this kind of approach? So I mentioned this idea at the beginning, and this word was here, genomic learning healthcare system. So this is the idea that you implement something genomic, you look what happens, and you figure out how to improve that implementation. So we're at the point of implementing. The NHGRI created a new network to do genomics-enabled learning health systems. We were successful in competing not only for the site, that's these three guys here, but for the coordinating center as well. And that was those awards were awarded in the fall of 2024. We've spent a lot of time trying to think about what the right first project is, but what we have done is create a logo for ourselves. So this is the logo for the Genomic Learning Health System. And more to come on that, obviously. So just to sum up, personalized medicine, I like to quote William Osler because he's a Canadian, as am I. The good physician treats the disease. The great physician treats the patient who has the disease. Osler's papers, by the way, are all at McGill. They're not at Hopkins or at Penn or at Oxford, where he continued his career. And this is a picture of one of our interventional cardiologists, John McPherson. He runs our internal medicine residency program now. And one of a patient of his into whom he has recently put a stent. And this is the first patient that we identified in our PREDICT program who was a star2 homozygote for loss of function in CYP2C19. And so what I'm fond of saying is that John knows a lot about this patient. He knows about her other medications. He knows about her life choices. She knows what she wants to have done with her life and what she doesn't. And now he knows a little bit more about how to take care of her. So that's what I think personalized medicine is all about. And these are the people who are key to some of the advances that I've shown you. You get your picture taken off this slide if you leave Vanderbilt. So there's a lot of people who have participated, but who are not on the slide anymore. So I'd be happy to take questions and or comments or anything else. So I'll stop sharing.
Thank you, Dr. Roden.